Hello, everyone. I'm Bogdan Milojković. I'm back for Nova Biomedical. I'm Global Medical and Scientific Affairs Director, and I'll try next 20 or so minutes to just to address issue around chronic kidney disease and opportunities we may all have for screening and monitoring in community setting. So just a very top line overview of chronic kidney disease statistics. This is from USA. The most talking one is the one in the middle that says that 9-10 adults with CKD do not know they have it. And prevalence is huge. In USA, around 15%, which is 1 in 7 adults, are estimated to have chronic kidney disease. 37 million people in USA only. 1 in 3 adults with diabetes and 1 in 5 with high blood pressure may have chronic kidney disease. So this number itself just show the size of the problem. It's more or less the same in a lot of developed countries, and in developing world, it's in some places it's even worse. This number 9 in 10 that don't know they have it. It's probably a bit less in UK because UK is better than other developed world in discovering CKD in early stages, but still the number is relatively high in UK. So talking about opportunities for monitoring of chronic kidney disease using point-of-care devices has been addressed in quite few studies and projects across the Western Europe. And this is one of the articles that summarize kind of opportunity. It's done by guys from Oxford, Chris Price, Carl Hennigan, Anwen Bruel, and their team. And it really looks as a kind of very brief technology update on opportunities of what you can do with creatinine point-of-care testing in terms of screening for CKD. So their conclusions were that creatinine point-of-care test, they can be integrated in primary care initiatives with annual or more frequent, if needed, creatinine point-of-care testing, especially in high-risk patients, to allow immediate action on significant result. They also talk that testing in primary care can make a case for safer prescribing and theoretically reduce some inappropriate prescription for medication that's excreted via the kidneys. Their case at the time, this study was in 2015, they're talking that currently at that time there was no robust evidence that was able to demonstrate technology's impact on patient outcomes or service delivery and any consequences that can come with that. So let me look in some studies that have been published since then that look in some of these topics. So first of all, let me address creatinine point-of-care testing performance, because that's raised fairly often, just to address that issue straight away, and maybe even to the presentation I mentioned a couple of times. So we actually had NICE that looked in point-of-care creatinine devices and their performance testing and assessed that and published in November 2019, so very recently actually. They looked in use of point-of-care devices to assess kidney function before contrast imaging with intravenous contrast. So they assess everything that was on the market that can be called point-of-care testing, and they found the 3 devices, ABL 800 Flex, iStat, Alinity, and Stat Sensor, are actually recommended to assess kidney function, with some caveats, obviously, when you will and how you will use it in real life. And quite few other devices here under 0.13 are not recommended. The main reason why they have not been recommended is there is a lack of data published. We produce Stat Sensor as Nova Biomedical, and we had the device has been on the market for 10 plus years, and we performed loads of studies, and we really had loads of evidence, and that helped us get actually this positive recommendation from NICE. What noting here that out of these 3 devices that are recommended, Stat Sensor, Nova Biomedical Stat Sensor device is probably the only one kind of real point of care, especially in terms of handling capillary samples, because our volume is 1.2 microliters, so really tiny blood drop can be used, while other devices are a bit bulkier in the terms of if you consider them as a point of care, but also need a bit larger volume of blood, and it's often used as a venous blood sample. So this is kind of official recognition of point-of-care creatinine device performance that can give some confidence in results. However, I want to mention a few other studies published also in 2019. This was a group from Belgium that looked in comparing performance of our device with a laboratory method. Here on the left, we have this chart. And on the right-hand side, actually looking in how eGFR calculated from our device compared to measured GFR by IHEXL method. And actually, they concluded the device has very acceptable performance and can be used for these purposes. The even larger study was published just recently, maybe a month or two ago, from South Africa. They looked at very large sample, over 600 patients, where they measured GFR, and they looked how different devices compare in terms of estimated GFR compared to measured GFR. So the top row is actually top row is showing the lab eGFR is on the left-hand side, top left chart. eGFR calculated by MDRD calculation, and then the middle one is stat sensor device, and then the third one on the right side is iStat device. And you can see using MDRD equation that our device stat sensor actually has a best alignment with measured GFR, again calculated measured by IHEXL method. And the bottom row, three charts are looking at CKD-EPI equation in the same order. Laboratory in the middle is stat sensor, and then on the right side is iStat. Again, the best correlation actually has been shown to be with our stat sensor device. Worth noting here is again is that our device, again using capillary sample, the smallest blood volume, will probably give you the biggest imprecision in a repeated measurement, just because of the small volume, especially if you're using capillary blood with all the issues that are coming as pre-analytical, technique in taking the capillary blood sample. Nevertheless, performance has been really brilliant in this study. So let's look now in where our device has been used in community setting and how people try to assess its usefulness in various applications. So looking at community setting, this is actually, again, very important and large study from 2021, published just in January. It's a large study supported by International Society of Nephrology called 0x25. I imagine a lot of you will know about it. It actually doesn't look in chronic kidney disease, but I thought it's worth mentioning it here. The whole study idea is basically reducing the number of deaths from acute kidney injury in low resource setting by 0 by 2025. Very, very ambitious goal. Let's hope we can all achieve that. But basically, the study was ICN funded, and it was done in a couple of countries across developing world, low resource setting, Asia, Africa, Latin America. 3 phases. First, they looked to they done observational phase, try to establish the baseline and to see what's the prevalence of kidney disease. Then for 2 months, they trained the people how to do point-of-care testing in the field and use actually consultation to care about these people. And then 6 months for the interventional phase, where they actually used our device to test people in the field and try to triage patients using telehealth methods. So their conclusions were that actually trial was successful, demonstrating the utility of their health assessment risk model, and they coupled that with point-of-care creatinine testing as well as urine dipstick test. So they were able to recognize early kidney disease and to do appropriate triage and management of these patients. Kidney dysfunction was associated with increased risk of mortality, and it was higher in patients with moderate severity of AKI. And it has been recognized that management of these patients was facilitated by a combination of point-of-care test and guidance with teleconsultation. So they're trying now, I think, to expand this as a future model of care in these low-resource settings. Another study, more like closer to home to you guys, done in England with the Royal Free NHS Trust. So Here we used our meters in patients who participated anyway in a cardiovascular disease screening program and audit of diabetes care pathway in community. And that was done in collaboration with Hindu temples where there were loads of people that would come for a screening. And in addition, they had a subgroup of patients that were post-renal transplant patients under care of nephrology team in Royal Free London. So point-of-care testing was done with our meter, and it was compared with the IDMS traceable method, laboratory method, Roche method to see what's the performance of a test. So point-of-care measurements are comparable to laboratory measurements in CKD diagnostic range, and this point-of-care testing could facilitate early diagnosis of CKD via screening programs as well as monitoring of CKD patients in a clinical community setting. This was published as abstract on a conference, and we hope a paper will be published fairly soon. So they're very happy with our device, and I think we are planning more projects like that to do various projects for screening of CKD in community. Now, another interesting setting is pharmacy setting, and I will show you a few examples there. So just as brief introduction, drug-induced kidney damage is well recognized, and it's on the rise because loads of drug here listed on the left can cause kidney damage. And therefore, there is a case to do something about it at the source where drugs are prescribed. So estimate is, this is article from 2008 in American Family Physician, that drug cause approximately 20% of community and hospital-acquired episodes of acute renal failure. So certainly there is a case whenever possible to test as early and as easy as possible for acute kidney damage. So this was studied from Netherlands. These guys have done the most in pharmacy. They were developing clinical decision support tool and optional point-of-care testing to test for renal function, for safe use of antibiotics in the elderly patients, so antibiotics that have potential to cause acute kidney injury. They had a very simple model how they would assess the patient, looking in existing medical records in their pharmacies where they actually have quite a good link with the GPs, and they could find in a lot of cases information already in the system. Where information wasn't available, the plan was to use the point-of-care testing device for creatinine and calculate eGFR. So key points from their publication is that the community pharmacies can use clinical decision support tool to detect inappropriate drug use in renal impairment, and also to discover lack of data on renal function if it is not in a system or it hasn't been done recently. And the efficiency of this clinical decision support in community pharmacies could be increased by better registration information of renal function. Even they suffer from lack of proper recording in electronic medical health records. And in the case of urgency, they suggest creatinine point-of-care testing by community pharmacies could be of added value, especially for older patients. So this was studied in 2017, and then in 2018 we had actually they've done that. They implemented it in one of the largest pharmacy chains in Netherlands, and they looked actually in the budget impact analysis of point-of-care testing in community to prevent antibiotic-related hospitalization in relation to acute kidney injury. So looking in all different parameters and models, actually they said that if they will have available information on renal function in all relevant cases, either by linking up the pharmacies with available data from hospitals or primary care physicians, or testing by point-of-care devices in a pharmacy directly, they could save over close to 20 million euros per year in Netherlands, which is an incredible number. So key points for decision makers from their studies that use of renal point-of-care tests could reduce the number of adverse event-related hospitalization from antibiotics, and using renal point-of-care testing community might be a cost-saving alternative to standard of care. Bear in mind, this was just looking at antibiotics prescribing, and think about all the other drugs that have to have dose adjusted based on kidney function, or that can cause problems with the kidney.
One additional potential usage is actually if we look in a home or self-testing. So let's look in a couple of real-world applications there. Bear in mind, our device is not approved for self-testing yet. We are working on it so that can very soon be option for various applications. So this was also in Netherlands, so application of point-of-care creatinine device for trend monitoring kidney transplant patients. They were thinking whether the device is fit for purpose, looking in performance versus lab, as I mentioned at the beginning, but also what are the patient experiences by using device at home for trend monitoring. It's worth noting that this population is very sensitive. Kidney transplant patient, that's kind of life-saving for them, and they're really motivated to do this. So here are traces from six patients looking at creatinine measurements against days since transplantation, comparing device from results from point-of-care device, our stat sensor device, versus central lab method. And you can see more or less in these patients, the device performed really well. You know, the trend monitoring worked really well. Patient was actually doing daily measurements, so and it gave them confidence to know, you know, their kidneys are performing well. So the daily results suggested that capillary blood testing can be used for daily trend monitoring after renal transplantation. Question was raised about accuracy of point-of-care testing with the central lab for a single point determination. So if you just look at a single point, again, I just put note here in bold, there was no comparison to measure GFR. So if you're talking about GFR comparison, we've seen at the beginning that our device actually performed quite well if you would compare it versus measure GFR by our Hexel method. And here they looked actually, that was 2015, they looked actually in patient experiences with self-monitoring of renal function. They wanted to know how patients feel about using actually monitoring their kidney function at home in a sort of similar way as they monitor glucose measurement in patients with diabetes. So the first part, the top question, are kind of positive statements, advantage of monitoring. And you can see that the scale was 1 to 5, so 1 was disagree and 5 is agree. So above 4 in the baseline and also follow up, the patient were very positive about positives of monitoring kidney function at home, that it can measure, look at creatinine regularly. Blood pressure, they also monitor in this study, that physicians have access to this data, that changes are noticed quickly. So all of that was very positive. While the bottom part is disadvantage, sort of negative statements and feelings, that the burden they would have measuring themselves, how they would analyze results, what it means for them, tracking values digitally. So actually, this wasn't a burden, especially after follow-up, all of that dropped almost to the 1, which disagreeing with this statement. So this shows actually that self-monitoring of kidney function at home has potential, especially for this particular group of renal transplant patients, to improve their care and give them more confidence in how they manage their health post renal transplantation. So very briefly now, what future brings and how creatinine point-of-care testing can be used in the future. Just one slide here. We know that dapagliflozin from AstraZeneca is coming. It's already approved for diabetes and chronic kidney disease linked with diabetes. But this is from USA that they got a breakthrough designation, and they expect to get approval based on the data they presented last year. They expect to get approval to use dapagliflozin in patients suffering chronic kidney disease of any cause. So there will be now therapy available that can help people not to progress with a chronic kidney disease toward kidney failure and needing transplantation or dialysis. That can be have a huge impact personally on every patient, but also on a healthcare system due to the cost related to end-stage kidney disease.
And then just one kind of title from a recent article looking at the technology, telehealth, and nephrology. It says time is now. So especially during the COVID, we know that chronic kidney disease patient and patient at end stage renal disease suffered a lot. That was the major risk for negative outcomes due to the COVID. But also COVID opened up venues for telehealth, and it's been used extensively across the world to manage patients remotely because of the pressure hospital phase from the COVID patients. So we believe that this shift toward telehealth and remote monitoring will increase, and opportunities that point of care testing offers will be recognized even more. This is how our device will look like and how it looks like. Very small device, same as any glucose meter, small strips, quality control, safety lancets, you prick the finger, very small drop of blood, you get results in 45 seconds, either in pharmacy or within a GP community setting, or one day, hopefully, at home for self-testing. So that's all for me. I don't want to keep you anymore. Please bring any question if you have. Thank you.
Well, thank you very much, Bogdan, for this very interesting presentation. It's a very interesting topic, from one hand, from the long-term point of view of the NHS, who wants really to put an effort on bringing care to the community. And on the other hand, for what we have seen during this COVID pandemics, where literally allowing patient monitoring without having especially elderly patient going to hospital, for example, is very important. There are quite a few questions coming along this line, and I will start with the very first one, Bogdan. So how a delocalized screening program can improve medication optimization and safety?
Thanks, Germano. I mean, that's probably very obvious from some examples we've seen in a talk, but I can give you some insights of the current work we are doing at the moment in some other places that's still not published. For example, in USA, the FDA has a large program that we are participating in with some pharma companies as a partners, looking at, for example, in medicine optimization. Actually, specifically, they were very concerned about the medication compliance of the patient of taking medications, and they are looking, for example, in patients with diabetes and related comorbidities, among them chronic kidney disease. So they want to see how whatever management you're doing in community can actually improve medication optimization, patient compliance, and outcomes at the end of the day. And as part of the program, they're introducing actually point-of-care testing, not just for creatinine and kidney function, but also measuring A1C and other parameters in these patients. And they basically want to show that these models, where you can do it in community, they're doing it in pharmacies with intervention from pharmacists to motivate the patient to keep on taking medication, to take the right medication. And they basically want to show that amount of money they can save by improving outcomes is huge. And as I said, it's supported by FDA, and it's a huge program. We're actually trying to do something similar in UK at the moment, working with a pharmacy group in London, and we hope to have a partnership with other relevant partners in UK, like patient charities and similar. So we hope to show the similar effect in UK from patient outcomes as well as from, let's say, health economic perspective. Coming to safety issue, that's exactly what the guys in Netherlands were doing, looking at antibiotics. But if you look for number of drugs that can cause the problem with the kidney, it's like almost any drug, I would say, on the market will have some issues. And being able to test before prescription is given and written to the patient, would have a huge potential to decrease some unnecessarily acute kidney injuries coming from prescription of these drugs. And we really hope, again, we are running several projects, also some of them in UK, where we can show benefits of that approach.
Well, thank you, Bogdan, about that. Well, you mentioned also cost optimization and cost benefit. And matter of fact, there are quite a few questions going exactly in this direction, Bogdan. So what about the cost of the community testing? And who is going to pay for it? The NHS, the patients, any other possible payer you can foresee?
Yeah, that's the, if I can speak for diagnostic industry as whole, we are kind of smaller brother or sister in that biotech world, where we know in UK that when NICE positively appraised medicine, clinical commissioning groups kind of have to provide the money for these new treatments. If we have diagnostic in the same way that shows some positive impact, health economic, but also outcome-wise, there is no that mandate for CCGs to provide this testing and pay for it. So that's always for diagnostic industry challenge. Nevertheless, if we are talking about CKD, I think the benefit will be so big that it won't take much convincing for NHS to take it on their books. I mean, we will obviously do the study, and we are working on these things, and we hope to provide evidence that will be very clear-cut, providing benefits, like the case in Netherlands. You know, they're talking about saving almost 20 million, looking just in antibiotic prescription. But to bring it kind of to the real world, I mean, we have that. I shown it in one of the slides. Where NICE looked at the guidance for using creatinine testing before contrast imaging. I mean, that's causing acute kidney injury from just contrast. And again, we are talking about, let's say, all the drugs that you're prescribing that can cause the same issue. So when they looked at that, they looked obviously whether there is a benefit also from health economic perspective. Our device, as well as two other devices, have shown health economic benefit. And, you know, as I said, how they look in a pharma world, they would have to, you know, NHS would have to fund that. We would hope they would fund that. But for our device specifically, actually, if you look in health economic analysis, device they use, the pricing they use for our device was the pricing for professional device, which has all connectivity options, different EGFR equations. It can be linked with the hospital system, high-tech device. And that device is 10 times more expensive than the small one we are bringing on the market to be used in community pharmacies or self-testing one day, as you said. So that literally brings that cost down tenfold. So if it was beneficial from health economic perspective at the price cost of 10 times more, I would definitely expect, with all benefits we have, that we can prove that the testing community with affordable device can really make a change. So I'm looking forward for years to come where we can have this implemented on a much larger scale.
And we are all looking forward to it, Bogdan. There should be quite a few other aspects that would really benefit from your comment. What's the role of IT and the IT structure in all these? Who are the different actors to be included, GPs or hospitals together with patient pharmacies? But we don't have time actually to go towards all these aspects. Anyway, I like to invite all the participants to ask their questions. There will be a member of Nova Biomedical in the networking lounge for the rest of today, actually to try to address all these questions. In the meantime, Bogdan, I thank you very much for your presentation, for your availability, and I thank you, all of you participating in this event, for your attention and your friendly questions.
Thanks a lot, everyone, and have a nice day.
Have a nice day.